Good morning and evening. Welcome to Pain Institute of Indonesia. My name is Fajri Rizki. On behalf of the organizing committee, we would like to extend our thank you for everyone who have joining in this digital dialogue of Interventional Pain Update Series 5. We would also like to greet everyone who have followed us from episode 1 and thank you for joining us once again. We are honored to have with us today our guest expert live from Turkey, Tolga Ergonenc MD. Today's webinar is brought to you by Pain Institute of Indonesia and supporting organizer by Eskolab Academy, a B Brown company. We would like to convey important message and guideline. Please note that your microphone is muted throughout the session. Please post your question in the Q&A section anytime throughout the session, and this session will be recorded. For today's agenda, after this, there is opening remarks by Pain Institute of Indonesia, and after that, we will start the ultrasound-guided diagnosis and interventional procedures for painful hip presentation by Tolga Ergonenc MD. And we also have question and answer with panel discussion, and then closing remarks. For faculty of the day, Tolga Ergonenc MD. Hi, Dr. Tolga, how are you? Dr. Tolga?
Maybe his microphone is off.
Yes, it's already on, doctor.
Okay.
No, Tolga's microphone may be off.
Okay.
Make sure his microphone is open.
Dr. Tolga, can you unmute your microphone?
Okay. Do you hear me now?
Yes, we can hear you. Hi, Dr. Tolga, how are you?
Thank you. Everything is okay. I'm doing well.
Okay. And without further ado, ladies and gentlemen, please welcome our host and moderator of Yosi Asmara Pain Talk, Yosi Asmara MD FIPM, FIPP, CIPS. Hi, Dr. Yosi, how are you?
Hi, Fajri, thank you. I'm fine.
Okay,
Hi, Dr. Tolga.
Hi, how are you, Yosi? Dr. Yosi?
Yeah, just fine. I hope we are everybody fine today.
I have also.
Okay, Dr. Yosi, the time is yours.
Yes, thank you, Fajri. Thank you, everyone. Thank you for all the participants that join us here in the YAP Talk, the 5th episode. Today we have more than 500, around 575 registered participants from this YAP Talk. And we have a special guest today is Dr. Tolga Ergonenc from Turkey. And also, I'm so happy that Professor Sudip Diwan also joined us here as a panelist for this episode. Dr. Tolga today will talk about the ultrasound guided diagnosis and interventional procedure for the painful hip. Before we start, I will read about the Dr. Tolga CV. Dr. Tolga Ergonenc MD is an associate professor of anesthesiology and intensive care medicine. He is a founder and head of the Akyazi Pain Center and Sakarya University Education and Research Hospital. Dr. Tolga is an anesthesiologist and reanimation specialist with a special interest in the ultrasound-guided intervention for pain management and regional anesthesia. Dr. Tolga graduated from the Uludak University Faculty of Medicine in 2000 and was awarded as a medical doctor. He became a specialist in anesthesiology and intensive care in 2006 and joined the Sakarya University Education and Research Hospital in 2006. and became a consultant in anesthesia and intensive care. He founded the YAP Pain Center in 2014, and he is currently a chief of YAP Pain Center. So uh, I'm not talking a lot again. The time is I giving the time for Dr. Tolga presentation. I think it will be good and amazing because he told me already that there will be a live demo from Dr. Tolga, not only presentation but also live demo. So Dr. Tolga, the time is yours.
Okay, thank you very much, Dr. Yosi. Um, you see my screen now?
Okay, yeah, okay.
Okay, I'm sharing my screen.
Yeah, okay.
Okay.
Okay, that's good. Dr. Tolga, you can start.
Hello again, and welcome to Yosi Asmara Pain Talk Zoom conference section of the hip joint. The next 1 hour, I will be talking about the hip joint, how to begin a routine examination with ultrasonography, and I will try to show some interventional procedures example. And I will try to do a little short live demo for you. In this presentation, I have prepared for you propositioning, anatomical illustration, and ultrasound image of the common skin at the hip structures. At this presentation, I have been using all my presentation complete anatomy platform, which copyright held by the 3D for Medical Ltd from Elsevier. I have an education license for this presentation platform. I hope you can enjoy and you can use this knowledge in your daily practice. Ultrasound machines are getting smaller and smaller, but smarter. All these three machines I use in my daily practice. For the hip joint ultrasonography, would be best to beginning talking about anatomy and the sonoanatomy of the hip. Sonoanatomy is totally different from the classical anatomy. You have to know differences. This is my educational license for this application. Okay, let's start the position of the patient during examination of the hip joint. For the best view of the sonogram, the patient position is very important. The patient position should be changed. Which compartment do you want to examine? There are 4 different compartments at the hip when you examine with ultrasonography: anterior, posterior, lateral, medial compartment. Some authors say that window, but it's not important which you are choosing, compartment or window. Position is important. An example for imagining anterior compartment of the hip joint, the patient lie, of course, fine on the examination bed with the lower lip and little bit extension and the middle and the mild external rotation. For the medial compartment, there is a different position. The mild hip and knee flexion with the external rotation and abduction of the femur might be necessary. It's like a figure of 4 position. For the lateral compartment examination, the patient lies spine position or contralateral decubit position, and might choose a contralateral decubit position. For the posterior compartment, the patient lie in the prone position with the leg in extension. And another important issue is the choosing transducer. multi-frequency linear transducer is suggested, especially for obese patient, high body mass index patient. Lower frequency or convex transducer would be required sometimes. Let's begin the anterior compartment. What we can see at the anterior compartment, the perp or transducer position as longitudinally parallel to the long axis, the distal femur. I always put my transducer at the distal femur, and the transducer should be moved to the proximally. And when the transducer turns 20-25 degree, exactly to parallel to the neck of the femur over the hip joint, this is a sagittal plane, we can see some anatomic structures. What are they? There's three basic movements, 1, 2, and 3. It's very easy. 3 different positions and 3 different movements. So when our transducer at this position, what we can see on ultrasonography, this is the basic and this is the most important sonogram about hip joint. This is acetabulum. You can see here. This is an anterior labrum. This is a posterior labrum. And you can see head of the femur and the neck of the femur. The joint of the head of the femur and the neck of the femur, there is a joint space. If you would like to perform any interventional procedure about the hip joint, especially intra-articular injection, your target is here. This is a joint space. If you move the transducer medially, you can see another anatomic structures. You can see 2 muscles. At this position, you can see these muscles. One of the muscle is psoas muscle and the other is iliac muscle, like this. And you can see labrum and acetabulum as well. There is another important structure we can see at this position. This is a iliopsoas tendon. This is a labrum. This is a head of the femur. This acetabulum here. And you can see iliopsoas tendon here. When you turn your transducer 90 degree, you can see this muscle and IP tendon with the axial plane, like this. This is an IP tendon. You can see clearly femoral head and iliopsoas. This is a IP tendon, iliopsoas tendon. At the anterior window of the hip, we can see some vascular structures as a femoral artery, femoral vein, and the femoral nerve. When you put the transducer parallel to the medial part of the inguinal ligament, like this, you can see sonogram. This is a artery, femoral vein, and iliacus muscle. This is also pubis. And you can see pectineus muscle as well here. Starting from the anterior superior iliac spine, the prop position is the parallel to the alignment to inguinal ligament. You can see the tensor fascia lata and the sartorius muscle. This is anterior superior iliac spine, and this is the acoustic shadow of the anterior superior iliac spine. At the medial side, you can see sartorius, and the lateral side, you can see tensor fascia lata. Starting from the axial view of the anterior superior iliac spine, the lateral femoral cutaneous nerve is usually seen immediately deep in the medial to the inguinal ligament attached on the iliac bone. This is actually shadow of the anterior superior iliac spine. This is an inguinal ligament, and this is a lateral femoral cutaneous nerve. But we cannot see clearly at this area like this. Another compartment is the medial compartment of the hip joint. For the middle compartment, mild hip and knee flexion with a hip external rotation and abduction of the femur might be necessary. We call that it's like a figure of four position. At the medial compartment, we can see some other anatomic structures, such as pectineus muscle, adductor longus muscle, and gracilis muscle, adductor longus muscle, and adductor brevis muscle, and the deepest muscle is adductor magnus muscle. When you put the transducer like this at the medial compartment in long axis view, the prop placed parallel to the alignment of the adductor muscles. Starting from the origin of the pubic bone, here, they can be scanned throughout their course. The superficial one is adductor longus muscle, and the deepest one is adductor magnus muscle, and between adductor brevis muscle. This is a longitudinal view. When you turn your transducer, you can see the axial view of three muscles. Muscles separate and layer throughout their course. The third compartment is the lateral compartment. There is some other anatomic structure, tensor fascia lata, and the gluteal muscle, and the greater trochanter. The transducer can be positioned axially on the greater trochanter. Tensor fascia lata tendons of the hip rotator cuff can be visualized over the trochanter major. This is greater trochanter. You can see clearly. The gluteus minimus tendon attached to the gluteal greater tuberositas, trochanter. Sorry, the posterior side gluteus maximum, and you can see the superior side, the tensor fascia lata. All these structures can also be examined in the long axis view. This is a great view of the greater trochanter. Anterior side, there is a gluteus minimus tendon. The posterior side, you can see the gluteus medius tendon. And a little bit posterior, gluteus maximus, you can see the structures, all the lateral compartment. And the last compartment is the posterior compartment. And the most important anatomic structures like a sciatic nerve is here. The superficial muscle, you can see the superficial muscle. If you use your transducer, the axial plane, and this is a sonogram of this view. This is a ischiadical tuberositas, and the superficial muscle is the gluteus maximus muscle. When you move your transducer to the laterally, you can see the sciatic nerve. This is an axial view of the posterior compartment. This is a sciatic nerve and ischium here, greater trochanter here. This is the most important anatomic structure of the posterior compartment. Okay, I would like to show some interventions. There is a lot of interventions about the hip joint, especially the most famous intervention is interarticular interventions to a hip joint. Usually use my transducer like this, and I perform to this procedure in plane axis. My needle exactly parallel to my transducer, so you can see the needle, all the needle clearly. This is the target of interarticular injection of the hip. This is a transducer position and the needle position. When you inject your local anesthetic or steroid agent or ozone or something else, you can see clearly expand the joint capsule. Okay, this is my patient. Sometime I will like to prefer after the injection with verified fluoroscopy. This is ultrasound imaging, ultrasound video of the interarticular injection. You can see the local anesthetic agent spreading and also fluoroscopic verify here. Over the neck, my contrast agent sprayed. We need to know some other anatomic structure is here and very important, such a lateral circumflex femoral artery. Why this artery is important? Because sometimes this artery could be our needle trajectory. We shouldn't puncture them. So before this injection, we need to see with the color Doppler. Anterior compartment, I said that there is some vascular and nerve structures. Sometimes we need to block to femoral nerve or hydrodissection to the femoral nerve because entrapment of this nerve. This is my transducer position, and it's in plane approach. You can see all your needle. Yeah, I said that there is three separate muscle, and they're attaching the pubic bone, and all three muscles tendon attach the pubic bone, and sometimes we need to inject the adductor tendon. Also, you can use in-plane approach or out-of-plane approach. When you use an in-plane approach, you can see all the needle clearly. This is an out-of-plane approach. So you can see all your needle. You can see only point like a dot in the point of view this. You can see, you cannot see all your needle in the out-of-plane technique. Where is the bursa? There is the bursitis. There is a scale bursa now, and you can inject bursa injection your transducer at this transducer position. This is a normal scale bursa, but there is bursitis view with the ultrasonography. Yes, there is other anatomic structure is very important. Trochanter major. And this is a greater trochanter. This is a trochanteric bursa. You can see the fluid collection with the trochanteric bursa. How we can inject into the trochanteric bursa? In the long axis view, my transducer position like this, and my needle position in plane approach. This is the end of my presentation, and thank you to participants for their patience. Thank you again.
Okay, thank you, Dr. Tolga, for the presentation. It's full of color and picture, and it's very anatomical, and it's very clear. Um, uh, do you want to do the scanning or something like that, Dr. Tolga?
Yeah, I would like to scanning a little live demo for participant.
Okay.
One moment, please.
Okay, Dr. Tolga will prepare for the live
Okay,
demo.
thank you.
And for all the participants, if you have any question for Dr. Tolga, you can write on in the Q&A section for the question. Okay.
Do you see my ultrasound screen?
Not yet, Dr. Tolga. Okay.
Okay.
Yes. Okay. Okay.
Do you see my patient?
Yep.
The most important thing, orientation of the transducer. Where is the right side? Where is the left side? We have to know this.
Yeah.
I'm using a linear transducer today because my model, who is my anesthesiology technician, Sardar, is a very tiny man. He's a very fit man. So I would like to thank you to supporting me today. Thank you, Sardar.
So now you're using the linear probe, right, Dr. Tolga?
Yes, this transducer four to uh, 4 to 13 megahertz.
Ah, okay.
First, we have to give a position. Okay, that's okay. This position is good. You can see the shaft of the femur
Yes.
as a hyper echogenic line. Now I'm putting the distal femur, the distal side of the femur, and move to the proximally,
Okay.
and turning my transducer. Jel alabilir miyim biraz?
So you're
We need
scanning from
more
the
gel.
distal to the proximal, right?
Yeah, now this is the distal side of the femur, and I'm moving my yes.
Okay.
This is a head of the femur.
Yeah.
You can see.
Yes.
You can see clearly. This is the head of the femur.
And the acetabulum.
This is the acetabulum. Yep. This is the cartilage of the femoral head and the capsule. Where is the joint space? Exactly. No effusion. There is no effusion. There is no effusion here. This is a perfect view of the femoral head and the cartilage. And the labrum, you can see the labrum. And the acetabulum.
Yeah. Very clear.
Okay, let's go to see color Doppler.
Okay. So you try to find the circumflex artery of the humeral, right?
Yeah, I'm okay. There is another artery here. It's not. Sometimes we didn't see clearly. Okay, I can see now. I'm scanning again. Okay. This is not a circumflex artery. This is another artery. We can see at the anterior side other anatomic structure. You can see the vessels. The compressible is the femoral vein. Non-compressible is the femoral artery. This side is the medial side.
Oh, okay.
Femoral artery and femoral vein.
Okay. And your probe right now is transverse or longitudinal or long axis? It's transverse?
Do you the axial plane? Do you see
Okay.
my model
Yeah.
at the screen?
Yeah.
I'm turning my transducer to the longitudinal plane.
Oh, okay. Ah.
And the femoral artery and the vein.
This is not nice.
Okay.
Yeah.
So other anatomic structure at the lateral hip. Thoracanteric bursa. Okay. That's not. Yes, this is you can see this side is anterior side. This side is posterior side. And you can see clearly to gluteal muscle attached to anterior side and the posterior side of the greater trochanter. And there is no trochanteric bursitis or effusion here. So this is a short axis view. This is the short axis view. I'm turning my transducer to longitudinal axis. Yes, this is a long axis view. Okay, there is no bursitis or there is no fluid intra greater trochanter bursa. There is lots of imagining about the hip joint. Time for demonstrate all of this. Thank you, Sardar. Thank you so much.
Okay. Thank you, Dr. Tolga. Dr. Tolga, we have some question here. We have some
Okay, I'm
question here.
starting now. One moment, please.
Yes. And then the first question is from Dr.
One moment, please. I'm
You can speak
returning
again.
my set.
Okay. Okay. Are you ready, Dr. Tolga? Okay. We have some question here. The first question is
Yes.
from Dr. Petra Sama. The question is, could you describe about pericapsular nerve group block? Oh, I know. This is the Peng block, I think, for the hip.
Yeah, especially pain block using after surgery sometimes we need the postoperative analgesia. We can use a pain block. Or I'm not usually use this block in my daily practice. So yes, it's important block for the postoperative analgesia, but I have lots of experience about this block, so I can tell lots of things about this. Sorry.
Okay. There's another question here, Dr. Tolga, from Dr. Carlos Contreras. Are you using cool RF in hip? This is for hip pain, I think. Do you use cool RF?
Yeah, I'm not using cool RF because of in my country's situation, this social situation, but I'm usually used to obturator nerve and the femoral nerve branch radiofrequency ablation.
Oh,
Not exactly radiofrequency ablation because I'm usually used to pulse RF at the hip joint pain. If nothing works straight and PRP or ozone, when that doesn't work, I'm using the pulse RF for the obturator and the femoral nerve sensorial branch.
Oh yeah, I see. When you do the pulse RF for that you told us that, do you use only ultrasound or you use fluoroscopy as well?
Combining with fluoroscopy.
Yes. Okay. So it is very it's a little bit difficult a technique for doing with the ultrasound. I usually do it with the fluoroscopy, but you do the combination. So you do it first with the fluoroscopy or ultrasound first, and check with the fluoroscopy.
I'm prefer ultrasonography for the avoiding vascular structure at this procedure. The main imaging technique for this procedure for me, fluoroscopy very assistive when performing this procedure because of we don't want to puncture of the femoral artery or femoral vein. We shouldn't do this.
Okay, yeah, I see that for the safety of the patient, yeah. So you use ultrasound first for the puncture, and then after that, check with the fluoroscopy. Another question is from Dr. Ahmad Yasin. How do you approach sensory part of obturator nerve for hip pain?
Under fluoroscopic guidance with anatomic landmark, especially the sensory branch of the obturator nerve is exactly can see you like a tear. So this is a good anatomic landmark with founding fluoroscopy. It's very easy. You know, tear.
Yeah.
Okay. This is the true and the correct place is this.
Okay. Another question. This one is a good question. From Dr. Franciscus Budijaya. Please let me know, why is the injection only at femur neck? Can it be done at femur head capsule? It means proximal than femur neck, from the neck of the femur. Hello?
What's the question exactly?
The question is,
what's the question exactly?
Can we do injection not at the can we do the injection to the femoral head capsule, not proximal, not the on the neck of the femur. Usually we do the in the neck of the femur. Can we? The question is, can we do it at the head of the femur?
No, I don't prefer this because I don't want to puncture of the labrum. So the labrum lie down the femoral head, and I don't want to puncture it. So my target is the junction of the femoral head and the femoral neck. We shouldn't puncture the acetabulum.
Okay. This is another good question. It's from Dr. John Francis Tepu. Can we make a diagnosis osteoarthritis with ultrasound? If we can, what is the appearance in the ultrasound of the osteoarthritis?
Okay, the ultrasonography, it's not the gold standard of the diagnosis of the osteoarthritis now. But you can see, especially Kellgren-Lawrence 4 and 3 step, the discontinuing to the femoral cartilage. In my model, Sardar, you see the perfectly visualizing and the perfect shape of the cartilage, the femoral head, the hip joint. If the cartilage disrupt, you cannot see the perfect shape of the cartilage. And the femoral head cortex may be disrupt, but with ultrasonography, you cannot see lots of more clue, especially Kellgren-Lawrence 1, maybe 2. It's not a gold standard diagnostic device for the hip joint osteoarthritis. I think that. It's my.
Okay, Doctor. The question from Dr. John, and then this is interesting from Dr. Ninandini Saresta. What do you do as a intervention for pain due to avascular necrosis? So the case is avascular necrosis of the hip. What do you usually do with the patient with this diagnosis, Dr. Tolga?
Okay. At avascular necrosis is very bad situation for the especially young patient. So the situation gonna be not better to better. It's gonna be worse. So the orthopedic surgeon want to perform replacement of the hip joint, but they are usually young patients, so they need to palliation of the pain. How we palliate their pain? I'm thinking all this, how we can help to palliation of the pain. PRP sometimes looks a first step, but I know ozone therapy is not very good option with the avascular necrosis of the hip. I'm focusing the pain, and I'm performing usually obturator nerve sensory branch and the femoral nerve sensory branch pulse RF. If the diagnostic block is positive, when I perform the diagnostic block and the diagnostic block it's work, I'm going to second step, pulse radiofrequency. About 1 year, some patient, maybe 2 years, they painless and living a good life, and the life quality better than past.
Okay, I will try to show Dr. Gusti Nyoman. Firman, can you show Dr. Gusti Nyoman so he can ask directly to Dr. Tolga his question? Dr. Tolga, I want to ask you, what is the most problem that you have at your clinic about the hip? What is the most cases that you have that in your clinic for the hip problem?
Osteoarthritis, coxarthrosis is the most common problem. And the second
Oh,
is, unfortunately, avascular necrosis. And the third is impingement of the hip joint.
so the most
Impingement also a bad situation for the young people.
impingement of
Hip joint.
hip joint.
Femoral impingement.
So usually for the osteoarthritis, what you do? Only the you do the RF or you do the prolotherapy or ozone or something like that?
I prefer ozone therapy.
You prefer ozone therapy?
Yeah, because of in Turkey, government cover ozone therapy.
Oh, okay. Dr. Gusti, let's see. Is there okay? Dr. Gusti Nyoman. Dr. Gusti Nyoman. Halo, Dr. Gusti. We try to show Dr. Gusti face right now. Not yet. Okay, okay, Dr. Gusti. Hi, Dr. Gusti.
Hello. Good
Yes,
night.
you can ask your question directly to Dr. Tolga.
Oh, yes. Okay, Dr. I can, well, actually, we can inject to bursitis case. We can inject PRP or dextrose.
Oh, yeah.
Okay, good question. PRP is the first choice, but in my country, PRP doesn't cover with the government. So the second choice is the ozone, steroid or ozone therapy. It's dependent on the patient position. I don't prefer a special diabetic patient injected with steroid. Maybe ozone therapy is much suitable than steroid therapy for the coxarthrosis or bursitis.
Okay, thank you.
Just only Dr. Gusti.
Yeah, thank you.
Okay. It's very interesting because I'm not too familiar doing the ozone therapy for the hip problem. I usually do the prolotherapy or giving a PRP for the osteoarthritis patient or combined with the radio frequency ablation. This is quite interesting that you do more for the ozone therapy for the hip. Are you doing to another joint problem with the ozone?
Sorry?
You doing the ozone only for the hip or other joint that you're doing with ozone?
Especially knee joint. I mean, usually use for the knee joint and the hip joint also as well. but we can use for the small joint as well.
Oh, it's quite interesting, this one, because I'm not too familiar with that. In Turkey, that's a lot. Ozone is doing. Many people, many doctors do it with the ozone in Turkey.
Ozone therapy is legal in Turkey, and but government give to some course and certificate to doctor. So after that, you can use ozone therapy. If you have a certificate of the ozone therapy, you can use legally, and the government covered this. But PRP doesn't cover in my country. So the patient have to pay money for the PRP. So it's not a good choice.
Oh, okay. We have another question here from Dr. Novian. Can we inject visco supplement in hip joint?
Yes, sometimes I'm using some viscous supplements, but when we have ozone, because of ozone have a regenerative effect on the hip joint or knee joint. We don't need lots of more viscous supplement.
So basically, the ozone will do the same. It is do the regenerative therapy, right?
Yeah, we need extra session for the ozone therapy.
So how many time that you have to inject ozone for the patient?
One time.
Only one time. So you don't.
So sometimes 2 times.
Oh.
Not
for how
3
many?
or 4 times.
You inject between 2 injection. How many? How long? Between 2 injection in 1 week, in 2 week, or in a month? Between 2
In a month.
injections.
In a month. In a month.
Oh. Okay. Okay. Prof. Sudhir, I think Prof. Sudhir.
I'm sorry, Dr. Jawan's in the OR. He'll be right with you guys.
Oh, okay.
I'll go get him. Hold on.
Okay. I want to ask Prof. Sudhir, is there any question from here? Dr. Tolga, what ultrasound that you use for the for your live demo?
Sorry?
What type of ultrasound that you use for your live demo? Is it butterfly? No,
It's
not a butterfly.
it's ultra portable transducer.
Is it wireless, right?
Yeah, it's totally wireless.
Okay.
This is a curve transducer. This is a linear transducer. It's totally wireless. You can use your smartphone or you can use your tablet. It's very easy to demo because of it's very easy to share screen. When you connect to this transducer with your tablet or smartphone, you can share easily your screen. I have 3 separate ultrasound devices in my clinic, but I prefer for this demo this device because it's very practical in my daily practice. It's very it's not heavy. It's very
light. Easy to carry, right?
Easy to carry.
And
yes.
easy to carry. And easy to carry everywhere. We don't have Prof. Sudhir, still not here. Okay, I will check. Is there any other question?
He's in the OR in the middle of a procedure, so he'll you guys as soon as he possibly can. I'm sorry.
Okay, it's okay.
Thank you.
Yeah. Thank you. It's okay.
Thank you.
Okay, we'll try to This is the question from Dr. Anwar.
Yes.
Which RF modality would you prefer for hip joint osteoarthritis? Full RF or pulse RF?
Pulse
Oh,
RF.
pulse RF.
Pulse RF. Because when you use a conventional RF, the neuritis not a good situation. It's very rare, but neuritis it's better than primary pain.
Oh, so you use pulse RF because you're afraid of the neuritis of the
Exactly.
nerve. Yeah. We have some
Exactly.
problem if the patient get the neuritis, right? the pain will go worse, getting worse because the
Getting
neuritis.
worse.
Yeah.
Getting worse.
Yeah.
I
I
don't
have
like
one.
it. I don't like it.
I have one case with that when I do the RF with the neck, with the medial branch in the neck. So the pain is gone, but the patient got a pain in the skin because I'm doing the RF. So I'm doing like you that right now I'm doing all my ablation using the pulse RF, especially in the cervical area. I have one case and it's very annoying.
I have 3 or 4 cases about neuritis. It's not a good station. Yeah. It's not easy to handle it.
Yeah.
So pulse RF, easy and safety.
Okay, I think we don't have other question. Okay, I will read it first. No other question. Okay, so hey, wait a moment. Wait a moment. I have the last one. I think. Oh, this is the question. What is your result about ozone therapy of knee?
Knee, the good question. I have good result, especially intraarticular injection of the ozone with knee. Hip joint and ozone results are good, but knee joint is very successful results for my patient, especially Kelgren Lawrence 1 or 2 and sometimes 3 level.
Okay, so we already finished all the questions from the participant in the Q&A section. Thank you very much, Dr. Tolga Ergonenc, for the presentation, for the good presentation, and also for the answering all the questions from the participant. And I have to remember all the participants that this is the 5th episode. We have another episode on August. I already invite Dr. Ana Carolina Braz from Brazil. She will talk about the sympathetic block for the chronic pain. And also, I already invite Dr. Andrea Trescott. She will talk about nerve entrapment on August. So I hope that all the participants can join us next month with Dr. Ana Carolina and also Dr. Trescott. So thank you again, Dr. Tolga, for your share expertise about the hip joint problem.
I would like to thank you to nice invitation, Dr. Yosi.
Yes, Dr. Tolga. So, Fajri, we are finished now. The time is for yours, Fajri.
Okay, Dr. Yosi. Thank you once again. Thank you for the excellent sharing and tips, Dr. Tolga. And it is very wonderful, insightful presentation for everyone. Before we leave, we would like to encourage all of the participants to participate in our polling or feedback of today's session. Right now, in the screen in front of you, there is a polling for you to fill in right now. And for the next episode of Interventional Pain Update, we will have digital dialogue with Ana Carolina Breslima, MD FIPP CIPS, Asra PMUC from Brazil. And don't forget to register and join our next episode. And the link is in the chat section. And stay tuned for any update in Dr. Yosi Instagram and Pain Institute Indonesia YouTube. And thank you for our speaker, Dr. Tolga Ergonenc, and our moderator, Dr. Yosi. And also thank you to our crew organizing team behind the scene. Today's event is brought to you by Pain Institute of Indonesia and supporting organizer by Eskolap Academy, a Biburn company. Stay tuned for the next episode and we'll see you and goodbye.